Our guest speaker has been profiled in national publications, including the Wall Street Journal, about the groundbreaking work that he has done with Safeway Corporation in the area of health engagement for employees. You know, since I've come to St. Alphonsus and the entire St. Alphonsus senior leadership, we worked with employers to find out how we can engage employees in their health, and with the coming healthcare reform that will be focusing on value, it's critical that we find ways to make certain that employees really care about the health care that they're receiving, as well as taking care of themselves. Dr. Kent Bradley, who is the Chief Medical Officer for Safeway and the President of Safeway Health, has accomplished these kinds of things, and he's come to tell us what he has done today. He joined Safeway in 2011 after a distinguished career in the U.S. military and as a graduate of West Point. He also has degrees from University of Minnesota with a Master's of Public Health, and also Daniels College of Business with an MBA. So help me welcome Dr. Bradley.
Thanks.
I got the cold.
Oh, that's right. I went to shake his hand. He reminded me he's got an upper respiratory infection, so he was nice enough. Well, it's great to be in Boise. If you heard my story of how I got here, you'd understand why I said that. And I also found out why I've heard that Boise is the one of the best kept secrets. And I know how you keep it a secret, because you make it so hard to get to. But I'm glad I'm here, and I'm excited to be able to share a little bit about the Safeway story. And I want to make sure I make time for questions and make this interactive. But I appreciate the attendance, and I'm going to frame this up a little bit differently. I'm going to do a little bit of an unusual kind of a presentation. I want to start us off where I feel very comfortable, and that's in the grocery store. And I want to take us down an aisle that none of us like to go down. You know, I know you go to the grocery store, and where do you go? You go on the periphery and you do laps. And then when you go to the main center aisle, what do? You park your grocery cart, and you run in there, you grab something, and you run out as if that's like doomsday. You don't want to go down the center aisle of the grocery store. I think healthcare reform is causing us to go down that aisle. I would say that oftentimes a lot of us didn't want to really understand what healthcare was all about. And our journey at Safeway caused us to go down this aisle and really begin to investigate what was on the shelves. And so this is a part of our story. And I start off with a clock because I believe that for us, we realized that the time was ticking faster than we thought it was when it comes to healthcare costs. Many of you are small businesses, large businesses. Like us, Safeway has a program where we support our employees with their healthcare. And back in 2005, we have an just so you know, we're a Fortune 50 company that has about $43 billion in sales. We have a 2 to 3% profit margin, though. We're a very low margin business, as most grocery stores are. And we found that after you figured it all out, our healthcare costs were in fact more than our net profit. Not a very good recipe for success for an organization, and especially as you saw an 8% cost growth in the horizon. So the wheels of time were ticking for us very quickly. In 2005, we took a retailer's approach to healthcare, and I want to share a little bit about that. But if you really dive deep and we go inside the insides of what is turning this wheel, we realize that it just wasn't Safeway. We were not unique in the experience of rising healthcare costs. In fact, nationally, healthcare costs were going much faster than the Consumer Price Index. And some would say that healthcare reform is not going to fix that. Some would say that till 2025, we may see a 10 to 12% rate of increase in healthcare costs. And as a nation, we wondered, are we getting the value out of healthcare when we look at other industrialized countries and their longevity and how much they spend on healthcare? What was the difference? So we saw that there was an issue back in 2005. And I want to share with you that a very simplistic approach that we took. we realized that healthcare costs, and if you're familiar with the triple aim was a term that's coined by Don Berwick for CMS of what we should be doing, and the triple aim is around reducing the per capita cost, looking at population health, and improving the patient experience. And we embraced that triple aim notion, although we started our movement before Don Berwick coined the phrase. But we recognize that if you want to look at cost, healthcare cost as a nation, we really have to think of it in a very simple term. And if you think about it, there's only a couple of variables. One is price, the price of the goods. Number two is the utilization. And number three is the intensity of that utilization. Well, as a self-insured health plan, we had some impact on price, but we found that the most important area that we could have leverage on is on utilization by keeping people healthy, and on intensity by managing things well. And we believed in our hearts that if we looked at those two factors that we had control over as an employer to some extent, we might be able to make an impact and put reins on healthcare costs. We knew that because when we looked at studies and we pooled data, we saw that a lot of behavior was a trigger towards healthcare costs. And this is an example of what we thought on an annual basis, in aggregate, on average, smoking, obesity, uncontrolled hypertension, lack of exercise, and uncontrolled cholesterol was doing on the healthcare cost equation. So what do? Back in 2005, we completely disrupted our whole market. We created a consumer-driven health plan, a more high-deductible type of a plan that allowed individuals to begin to at least understand the dynamics of healthcare costs. We wanted to begin to enable individuals to view healthcare as a consumer would, as if they're going to the grocery store, and then encourage health behavior. And from that, in late 2010, we started a company called Safeway Health that tries to help other large organizations look at it the same way. So, here's the story. And the story begins with us looking at what's on the shelf. And this is where the metaphor of a grocery store aligns and creates a contrast. It aligns because when you go to the grocery store, you're looking for affordability. You know the prices that are on the shelf. You also know, and if you're a smart shopper, you're looking at what's in the ingredients and you're searching for value. Increasingly, there are pressures that cause you to want to look for value even more. At the same time, the grocery store industry is not a very good metaphor because, face it, when we need healthcare, and we're going to pay what it needs to pay, and we want the very best. So in some senses, it's a good metaphor, but it also creates a contrast. But I want us to go down and look at some labels. And the first label I would say is that we had a great strategy. That value flywheel that I showed you about creating a benefit design, enabling consumerism, and then encouraging behavior, that's great, but I like Winston Churchill's view, and that is, however beautiful the strategy, you should occasionally look at the results. And we're fortunate because we began measuring things back in 2005, and we can look at some of the results, and that's what I'm going to share with you. The net is that over 2005 until 2012, our total health plan spend has averaged 2%. That's compared to a national commercial employer health plan spend that was on 8%. That difference was $410 million. That is specific to our health plan members, which is only 21,000 employees. Because a good number of our employees, and we have about 180,000, were either part-time or they were under union negotiated contracts. One of the genesis or one of the impetus for our Safeway Health organization to stand up was an opportunity to actually consult back to those multi-payer trust funds to help them reduce their costs, which then would help us with our negotiations around pension. So it created a nice synergy. But this was our net results. And I want to share with you that if you're going to talk about this area, there is no silver bullet. But if there was, if it's on the equation of utilization and on intensity, therefore, it's got to be around behavior. And if it's around behavior, it's got to be around engagement. So Health Affairs, one of the premier policy journals back in February, Susan Densler, came up with this notion of engagement is the next blockbuster drug. Because we have great technology and we have great medications, and I'm a big fan of the future of pharmacogenetics, but at the end of the day, if you don't take the pill and if you don't do what you're asked to do, it's not going to matter. And so we wanted to look at, and we believe that engagement is the next blockbuster drug, and there's a lot of value in just being able to do what you know you should do. Well, what's the problem? Well, it's actually biblical in origin, in the sense that Rome, in the book of Romans, Paul said, you know, I know what I want to do, but I don't seem to do that which I know I'm supposed to do. I mean, human behavior is complex, and I don't want to oversimplify this issue. We also know medication compliance, and you can think of it in your own life and my journey that it's difficult to do what you know you're supposed to or should do. So this gets into the fact that at the end of the day, we can create a strategy, but I have a saying that culture will eat strategy for lunch every time. And so in order to make the strategy work, we had to take a long view. And that long view was beginning to work on this notion of what is the culture of our organization, which I believe is really the culture of a community. You see, when you think about culture, it's really people coming together and agreeing and creating a norm of behavior, and this is how we do it. Whether that's the culture of your family, whether it's the culture of your community, whether it's the culture of your workplace. And so we took the long view saying, what is that culture? And for us, the culture was around activated individuals who began to view themselves as consumers, that they had a reason and a responsibility and a stewardship around healthcare, around the choices they were making, around their own behavior as well as that of their family. And so this culture of health was part of that long view that began in 2005. And we went into it and in a way that recognizes that change is difficult. So really this was a change management task. Some people had already bought in. And we knew we weren't going to get 100%, but I'm a preventive medicine physician by training, and so I'm all into herd immunity. I just wanted to get enough folks on that wagon. And so when I look at it, these are some common barriers to change. We already have beliefs. Individuals coming into us have beliefs about their own ability to change, about health, about whether or not, I used to say I could never run a marathon. I'd said that emphatically. I cannot run a marathon. I did a midlife crisis. I ran a marathon. But I had a belief, and that belief can only be changed in some fashion by an experience. And so we began to think about how do we create experiences that challenges or creates a new belief. One of those programs which I'm going to talk to you about is this program around simple changes, and we really began to ask people to commit to some simple changes that changed their experience and therefore began to work on belief. We also understood that there's fear. I was afraid of failing with the marathon concept, or fear that I was going to hurt too much, or whatever the fear was. We had to understand that there were assumptions that fueled that fear. We looked at time. Time is an important issue. And so we looked at how do we help individuals with prioritization? How do we create an environment that was accepting for you to go work out, accepting for you to manage your time in a way that was a good balance for your stress? So things that we as an organization can have some control over. Ability. We realized some people just didn't know what to do next. So there's a need to begin to look at skill development. Literacy. We have a very diverse workforce, and I would say that even in this room, if we were to ask individuals about certain health concepts, there would be differential in understanding. And so we had to begin an education campaign. And quite frankly, we have to understand that there's competing interests, and we have to understand that at the end of the day, for some individuals, it's kind of a Whipham principle, which is what's in it for me. So we began this journey, and I'm going to just simplify it into some tactics and techniques that went into a program. In our tactics, it's very simple. Whatever program we launched, it had to be personalized, meaning someone felt like it was for them. It had to be simple, and at its root, it has to be effective. The program had to have evidence. And if it didn't have evidence, and sometimes we were kind of pushing along the edge of some of these concepts, we had to be able to document to see whether the evidence supports its continuance. The other aspect then was this whole notion of the techniques, which I really call these incentives or influencers to get people engaged. And so we started looking at marketing principles that we use in the store, and things like incentive. Now, if strategy gets eaten by culture, I will say best intentions get eaten by incentives. Incentives can impact significantly. Now, in this notion, we're talking about financial incentives, but one could say that most of these are incentives. There can be non-monetary incentives. Social proofing could be an example of a non-monetary incentive. Social proofing is this notion that people are impacted by others. And so we look at how to message and portray things in a way that understands the social connectedness of us as individuals. Competition is a way to do some of that social proofing. Authority, the fact that we had to have senior leadership buy-in and visible buy-in was really important, and that is nested throughout the organization. It has to be fun. You have to like what you're doing, so how can we make something that's fun? The fact that we can make commitment to consistency, that if I can get you to verbally, and better yet, written commit to something, much more likely you will be consistent with that commitment and follow through. And choice architecture, we understand that in stores. We understand where to place that can to get you to buy it. We understand that well. So how do we begin to look at the choice architecture in our own organization, whether it's a non-smoking campus, so if you're on the property, you're not allowed to smoke, or to subsidized inexpensive meals at our cafeteria for healthy food, to making things convenient for fitness. In other words, building gyms on our corporate campus and having gyms being built increasingly in other locations. These choice architecture things have an impact. So those were our techniques. At the end of the day, we want an individual. What was our end state? An individual who was aware of their health and the fact that they were accountable for that health. And I want to share with you, this is just a couple of things that we've done. This is actually a video montage, but we started a significant campaign around the various things that we'd want to send out to individuals. We also realized that individuals were increasingly mobile, so we got into the mobile space. This is one application that had to do with actually healthcare cost. We made sure that the health insurance card was on your mobile phone, so you had it all the time, and then you had the ability to look at healthcare costs. We also looked at ways to do that for pharmacy, and so we looked at therapeutic equivalents and making sure individuals had an understanding of that. But most importantly, we understood this was a journey, and that this wasn't going to be a change that took 1 year, that we had the long view and we're going to try this in multiple venues, in multiple ways, and stick to it. If it was at Jim Collins in his Good to Great talked about the importance of persistence. And so we took that persistent view. Well, I want to show you some of the programs and just some of the things that we've done. One is this, what a lot of companies have done is these wellness platforms where you're tracking people's activity. We changed vendors several times. We've restructured this. We now have a year-long program, and we are constantly working on this, but we never changed the notion that individuals found value in tracking their health and that there would be a single portal for health information. What we did was we added to it. We added to it a social discussion board. We added to it video. We added to it a mobile application. So we took that same concept and added to it. We went mobile as well in the area of social connectedness. Remember, the social proofing is a big construct. So we understood that if we wanted to get at behavior and we looked at the drivers, we knew that it was obesity. We knew it was smoking. We knew that it was fitness related. We also knew it was alcohol related. And so there are certain things, I call them the unmentionables. It's very difficult to get at in a health promotion campaign and around lifestyle. So we began to look at ways that people can connect in support groups. And so we launched this in March. It's a virtual support group with complete anonymity where you can join AA groups, you can join Narcotics Anonymous groups, you can join smoke cessation groups, all sponsored by us for allow you to have that anonymity, and you can do this at home and your family members can do it. So this is a pilot. I don't have any evidence. This is one of those early things where we don't have any evidence on, but we're watching this closely. We also understood that it's more than just a couple of programs. It's quite a few things. And we kind of look at it as the behavior-based plan, wellness program, supports programs, and decision support tools. And we also began...
This is Phil's story.
I'm going to talk over this. We also understood that how people are communicated becomes very important.
He considered himself healthy.
So we started to look at the fact that we have televisions in the back of all the stores, and we started to realize that a lot of people are visual, and so we can't just do print media. We need to do more and more video. So you have collateral, which is your print, your video, your telephonic, you have the material you have, and then you have how you reach individuals. So we took a multinodal approach, and this is actually a true story of one of our employees who changed his life, and then we depicted it in a cartoon, and you can turn it up.
But hadn't thought much about what he ate. His favorite meal was a 16-ounce steak.
And then this gets posted as a means of getting individuals excited about taking their healthy measures so they're aware, because this person actually went to the gym and thought he was great. And you know, those of us in healthcare know there's hypercholesterolemia type 2, and that's a genetic thing. I mean, this is a type of thing that where somebody needs to be on medication. He was no idea his cholesterol's in the 400s. And you know, he had a heart disease risk, and because he became aware, he started to change his lifestyle. He also changed his diet and did some other things. But at the end of the day, you know, he attributes the fact that we started this program. By the way, our Healthy Measure program is completely voluntary. We tie biometrics to incentives. We tie biometrics to a premium discount, and we help form what is known now as the Safeway Amendment and healthcare reform, and it basically takes 20% of what is a part of your health plan spend that could be linked to either a health contingent type of a program like ours, or what we call an outcome-based program, or that of a program that's focused on participation.
By changing his food choices.
So that's one of the videos. Here's another video I thought I'd talk with you about. It's our program around simple change. We've got dozens and dozens of these videos. Go ahead and turn that up.
I had reached close to 200 pounds. I went to my annual physical, and my doctor told me that my cholesterol was really high. I was carrying weight in my midsection, which is really unhealthy. And on top of that, my family also had a series of heart disease. And so I started to run. But I started to run really quietly in my basement on a treadmill, and I started out slowly to try and get comfortable with the movement before I started to run in front of other people. In June of 2009, I ran my first 5K at the Safeway Father's Day Walk Run for Prostate Cancer, and I ran it in about 36 minutes and crossed that finish line and felt so incredible. And I was totally hooked, and I started to run. I started to incorporate running into my daily routine, and I started to lose the weight. And as I started to lose the weight, I wanted to eat healthier to ensure that I was fueling my body better. The simple change that I started to make with running led to many simple changes. So with my diet, with my exercise, but also with my stress management. I used to be a frequent lunch on the run person. Whatever was convenient was usually what I ate, which often was not a healthy option. And I started to instead replace the bag of chips or the chocolate bar with a jog at the end of the day. I started my weight loss journey in 2009, and by 2011 I had lost over 55 pounds. And so often when I say 55 pounds out loud, it makes me think that I lost a small toddler off my body, which is pretty incredible. And I'm even more proud that I've been able to keep it off.
So we in this campaign, what we do is we give gift cards for people to nominate somebody, and then what we then do is we interview them, or we have them just send in a video. That this person just sent in the video. They went to their local broadcasting group that's found in the division, and then she just went in. We have others where it's kind of a personal video kind of a thing, but we have a lot of these videos now going out. And you know, we honor all sorts of changes. Honor a change because you're over 50, you finally got that colonoscopy that you're afraid to get. I mean, things are important in our health journey, and we want to honor those kinds of things. So that's one of the other ways we began. And you could begin to tie this back. Remember the beginning notion of some of the principles we used around authority, around social proofing, around liking, around choice architecture, around incentives. We really started to focus on these, and we are actually studying these in a very intentional way. We also realized that we wanted to have these fun events. This is our Executive Vice President for Safeway, Larry Renda. And she kicked off the challenge in July 30th of a year-long challenge where we wanted to tie this also to volunteerism because we believe that health is much bigger than just
and you're going to find out
physical fitness
really
and other
things.
It's a mental
really
attitude as well.
And I absolutely can't wait.
This is just a montage of that. Well, I don't know about you, but I am absolutely pumped. Safeway is just so awesome. We have so many passionate individuals. So we appreciate broadcast these events, give one another corporate office, but at the same time, there's actual cheerleaders and groups that are simultaneously joining us. Of course, we're fortunate that we're a large company that has the ability to do these kinds of things. But at the end of the really at the bottom line is that we wanted to be able to have fun events, show leadership involvement, the authority piece of it, and really get this notion that this is how we do it here. It's normal. It's okay. This is what we expect. This is what we are all doing together. I want to just focus a little bit on the fact that because a lot of the things we're doing, you read about, I don't know if anyone's read the recent release by the RAND Corporation on worksite wellness programs, but that just got released just a couple of days ago. We want to be one of those companies that informs the research on this area because we feel like we've been given the fortune of being able to start tracking data, and that's what this slide was supposed to share. So we also found that we wanted to be a learning organization. So in the healthcare space, data is tough. And so we felt it was really important. We need to have our medical claims data, so we worked to get that. But we didn't stop there. We have we have it all de-identified and aggregated by a third party. But we started building a very robust, actionable dashboard that we couldn't find anywhere else, so we just built it with a partner. And so now we are able to really get down to some really interesting statistics and ability. And it goes everything from disability, HRA surveys, work comp, to specific programs like Jumpstart. Jumpstart, by the way, now has over 28,000 members that are part of the program in less than a year time, and we've accumulated over 90 million wellness points as an organization. So we're pretty proud about that. But the key is having the data now to look at the return on investment. I think as a business, we owe it to ourselves to understand what it is that these programs are costing us and whether or not there's a return. You know, if you read the RAND Corporation, they cited that there's general literature saying health promotion type activities, if done right, seem to return about 3 to 1, especially if you create all-in costs, not just medical claims costs, but you throw in productivity, you know, the work comp, but there's very little data out there. And so we have that kind of data now, and we're starting to understand our specific programs. We're also looking at it in novel ways. Our latest is we're looking at influencers, and we're looking at who is influencing whom, and trying to create an algorithm around influencers and social connectedness. And these are some of the results. In a cohort from 2008 to 2012, for those who didn't pass their biometric, and this is voluntary, and 80% participated of employees, the overall average over 5 years was about 74%, but in 2012 it was 80%. We saw a decline that's statistically significant on all member cholesterol, as well as for those who originally didn't pass the standard. We also saw that BMI improvement increased. We have a rebate program. If you have 10% weight loss, then we give you a whole year's back in premium at the end of the year. So, that's a big incentive. And then that is what we see here is it's having an impact even on those who are the more difficult to move across the mark, which is our obesity type 3s or BMIs 40 and greater. So we are we see movement in the right direction. Of course, you're going to see folks that move in the other direction, but that's some of our data there. And then when we look at costs, we notice that those who passed all their biometrics cost us less, which is what we thought, and that those who passed none of them cost us 40% more over a 3-year average. So there's some fluctuations there, but it gave us the impetus to say, okay, we're on the right track to incentivize this and encourage individuals. I think the most impressive thing, and I don't know if I put this slide in there or not, now this is the sustained behavior. This is impressive too, that when looked over time, we saw a good change after the first year, but we wanted to know what was the change 4 or 5 years later. So this was tracked for 5 consecutive years, and then we measured those individuals, and we saw that those who originally failed in their cholesterol, so the cholesterol was over 240, 63% had passed 5 years later. So it may have been 70% at the first year, but that's called now sustainment of change. Nicotine is interesting. We actually measure tobacco use. We don't just use self-reported data, and we have 37% of those who had positive nicotine. Now, first off, if they're going to get tested, it's voluntary. They're declaring that they want to stop smoking, right? But the fact that 5 years later, 37% tested negative, that's a really impressive result for us. Now, yeah, so the slide that isn't on here is the fact that we tracked over time those who have consistently passed their biometrics, all their biometrics, as they aged, as a cohort, their costs have actually gone down. So that was another interesting statistic we found in our data. And so we really believe we're into this whole consumerism space. I think healthcare is really starting to catch up. St. Alphonsus, other health systems are really starting to look at the fact that healthcare has gone from a wholesale to a consumer marketplace in a lot of sense. And so we believe that consumerism is really starting to catch on. And so we understood that there were these health risk assessments that really is a predictive model around cost at the end of the day. Then you had these patient activation measures, the PAM that was developed at Oregon State University that talked about people's stages to change. But we wanted to know, what is there to tell me whether or not a person is thinking like a consumer in the health space? So we just decided to commission a study and create a survey instrument that we hope to become a national benchmark. We're going to release it in September. We're partnering with the Alternative Institute, which is a nonprofit research organization. And we just finished validating the instrument, and we'll be releasing it in the fall. The other thing we started to do is realize that when I talk about engagement, it's about relationships. And how do you keep a relationship? You follow up with them. I'm horrible with that. I've traveled in the military. I'm gone all the time. I don't call people like I'm supposed to, and relationships suffer. Facebook has allowed us to stay in touch. And there's almost instant feedback, right? You post something, you get something posted back. So that feedback's really important. So we started to think about this from the aspect of feedback. If we want to increase our engagement and our satisfaction, we need to be increasing this feedback loop. Make it very powerful. And what are those feedback loops? So I think there's a feedback loop between the payer and the provider, between the provider and the patient, between the patient and a program that they're involved in, and a patient to a patient. And so we're thinking about how our programs fit into this. We just started a program on the patient to provider loop. And so this is a launch on a beta. We have our own primary care center, patient center medical home on our Pleasanton campus for our corporate employees. And we're launching this in the orthopedic arena. And this is just a notion of a provider through an algorithm, evidence-based method, sending out notes to the patient and asking the patient to do certain things and then answering it. And then it goes back into a data system that creates a dashboard and an alert mechanism. When something critical, they're weighted, their loops are weighted, when something critical doesn't happen. Early results are pretty encouraging. 85% of patients feel more connected and satisfied with their physician. 86% of the patients ask questions or leave comments. 82% of the patients avoided a phone call or an office visit, and we think there may have been, for that particular orthopedic study, 21% reduction of preventable costs. We want to expand this into work comp. We think work comp has a great area, and we want to expand this into the patient-centered medical home. So I think feedback is a real critical concept, how each organization wants to think about that, but the principles, I think, very, very powerful. So in a nutshell, we went down the aisle. We saw various options. We have lots of other options that we're playing around with, thinking about, and trying to study. But I think all of us need to go down that dark center aisle of the grocery store and linger a bit, understand what are the dynamics in your community. And then perhaps, like us, you'll see that this is not such a difficult thing. We can actually do this together as a community, whether it's the community of Boise, whether it's the community within your own business, and begin to structure something that will have an impact. Because at the end of the day, what excites me is that we are helping bend the cost curve, but we're doing it through enriching the lives of our members. So with that, I will open it up to questions, or however you want to do it, Steve.
Well, that was a really impressive presentation, especially for a guy who spent the night in an airport trying to get here and making certain he managed to give this great presentation. So thank you very much. We appreciate that. So I'm sure many of you are going to have some questions, and we have people with microphones that will be able to bring those to you. Wait for the microphone to come to you. Also, we have the availability of microphones and questions from Baker City that will. So with that, can we take some questions? And I'm going to start off with the first one, since I actually have the chair for the moment. So you mentioned one of the first things that you did was change plan design. So how did the employees react to that plan design, and how important is plan design to be able to get success?
That's a great question, and I will say that in general, it went a lot better than we thought. And I think that's a lot of the experience when you think about a major change. You have all this fear. Let's talk about the change construct that we put up. We have a lot of fear because we have a lot of assumptions. And we have individuals who have certain beliefs about what the benefit should be, and they're concerned about the experience they're going to have when the benefit changes. So a big portion of change management, in my opinion, is pre-change communication and effectively finding influencers and talking about this as a way that is and framed in a way that changes the discussion and conversation. And so we did that. We did town halls. We talked about when you talk to a business and you're employed by that business and you just highlight the fact that your net profit is lower than your healthcare costs, and it's rising faster than your 2 to 3% profit margin, people will begin to get that this is kind of an all-hands-on-deck moment. And so we had that opportunity because of the nature of our business and where we were at back in 2005. But I think it went a lot better than a lot of people would suspect. I can't promise that for everybody, but for us, it went a lot better than we thought.
Great answer. Thanks so much. Dr. Ellsworth.
So when St. Alphonsus starts this program next year, hopefully, you say there's 80% participation because it's a voluntary program. So what are the health care costs in the 20% that don't sign up versus the ones that do?
There's a $1,000 premium difference because under the HIPAA and now under the Affordable Care Act, it's 20% of the health plan, average cost. For us, the medical spend, averaged a little over $5,000, so we could go up to $1,000 of that could be differentially applied. And under the Health Care Reform Act, it's raised from 30% starting 1/1/2014 up to 50% if you include smoking. And the final regulations on this got published. I'm just saying this, I'm sure you know this, but the rest of the group. So to answer your question, it's a $1,000 differential for those who choose not to participate.
So is it the sicker people or whatever that don't participate?
No. In fact, I didn't, it's hard on this kind of a construct to go back to the slide, but they actually cost about 20% more than those who passed everything, but less than those who didn't pass any. So we actually had a mixture, and it made sense to me, and I looked at the age demographics, and we actually did it by socioeconomic, because we understand salary ranges. So we looked at it at gender, we looked at it at socioeconomic status based on income, because and it wasn't significantly adversely affecting one population or another. What we had was individuals who, what I call the choice architecture of default. They automatically enroll and they just don't think about it anymore. It's coming out of their paycheck and they just forgot to get tested. So that's a part of that group that didn't get tested. Other part are individuals who just did not trust that this data wasn't going to be used somehow negatively. And that's a constant factor of our culture, trying to embed that this is not going to be used as a discriminatory thing, but in the sense of that your data is going to get sent out.
So if you join up and you are pretty sure you're not going to pass, say, 3 out of 5 of the biometric tests, and you don't want your employer to know that your cholesterol's high and you're overweight, do you spin this off to a third party so that you don't have somebody in your system that does all these tests so that the employer knows? Do you spin this off to a third party?
Right, so individuals get tested. They go to their physician. They have multiple avenues. They go to independent labs. We can do them in our stores as well, by the way, in certain stores. But you can go to multiple venues. They get tested. Now, this is a critical point in the biometric that we call it the Healthy Measures program. What's different from a lot of programs is we link the premium to the fact that you pass. And a lot of people just incentivize the fact that you take the test so you're aware. But we link and so that makes us kind of out there in the 7% of all, only 7% do this, of all companies that have any kind of program like this. The difference is this: when you lower your cholesterol, which means or your blood pressure, which means you're now under physician management like you're supposed to be and compliant, you get a 100% rebate. So at the end of the year, we give you a full year. At the end of the year, when you get retested, you get all of that year's premium back, and it applies to your future premium for the next year. So it's a twofer. And we feel that's a just way of doing it to reduce the concern that I'm not going to get this premium, there's no way I'm ever going to, because the things you choose, you have to choose things that people can have an impact on. And in general, I would say as healthcare practitioners, we would hope that we can address hyperlipidemia and hypertension, 2 known risk factors. BMI is a little more difficult, and so that's why we chose the 10% weight change. And then nicotine's probably the most difficult of them all. But we've held true to our standard to date.
So last question, then I'll give this up. So an employee comes and he passes all 5 tests. What is the approximate amount of the reward or the decrease in premium?
So in total, it's $1,000, and that we've debated whether or not to increase it to $1,500 next year. I don't think we will. We're debating that because we got to, and we're definitely not going to go to 50% because if you looked at the $1,900 difference, it doesn't really make, the finances don't make sense. So I think we might, because you want to incentivize just enough financially. There's other incentives we could use. It's not all incentive by finance. So we think the sweet spot is, so far for us, around 20%. Other employers, it might be 5 or 10%. I don't know. If you read anything by Volpe, who's written a lot, he's a physician and an economist in the New England Journal, he published that he thought $200 was the magic number. I don't know what the magic number is. But for us, it's 1,000 split over 5 measures, but it's not 200 each. He probably was looking at our data when I think about it. But what he didn't know is we changed the amount for each one a little bit. And why do we do that? If the amount that's coming out of your paycheck, we wanted to make sure that was very difficult for you to really know who tested on what, past what. So we changed the amounts, and we don't publish. The employee knows what the amount is, obviously. But if you passed one or not the other, it'll be tough. So we weighted a little more heavily BMI and nicotine, and that as well is up for discussion for next year. Does that answer your question? Okay. The one measure I didn't mention is hemoglobin A1C. So we're doing glucose, but we recognize that 24% of our individuals, because we also did hemoglobin A1Cs, 24% of our individuals with fasting glucose that was normal had an abnormal hemoglobin A1C. That was shocking for us. We decided to go with hemoglobin A1C because for those of us who treat diabetes realize it's so important to get this early. So.
And of course, diabetes has doubled in prevalence in the last 10 years in Idaho. Another question.
What about family members? How are they involved at all?
Yeah, that's a great question. So family members participate as well, and their premium design is influenced by that for adults. For children and 26 and under, they don't participate. We launched a trial, which we didn't do. We didn't continue in 2012, where we encouraged and we just gave an incentive of $200 if they would take a form to their pediatrician and have a discussion. And all we ask is that you just send in that you had this discussion, but in that discussion you actually measured certain things. But we discontinued this, but we've revamped that. We're calling it our My Total My Well Family campaign, and we're rethinking how we message. And the Jumpstart platform and our wellness platform is open to children. And we pioneered with a group that we've chosen not to continue with, but they actually did pretty good work, a program called ZAMZ, if anyone heard of ZAMZ from Hope Labs. But it was a tracking device, but and we incentivized that with prizes, but we stopped doing that.
Other questions?
Have you changed the layout of your Safeway stores to encourage what people purchase?
It's a great question. So at the end of the day, we believe in choice. We are changing our stores. In fact, to be frank, we still have the loop around the periphery. But what we also have done is changed our center store. So we call it our Center Store Initiative. It's a pretty sophisticated name for the project. And what we've done is we're breaking it up, adding lights. We do have checkout counters that are increasingly having healthy products, healthier for you type products. We've added an educational campaign, and we're putting a lot into making this portable. It's called Simple Nutrition, and we've got a beta site on an application that allows you to quickly mark the kinds of things that you don't want to have, like high salt, you want low sodium, and then it'll automatically help you figure out in the store what's good for you. And then we're rebranding our corporate brands, Eating Right, to a much more simplistic, focused way of educating individuals. But as far as placement in the store, we've changed placement, but part of that still is market-driven as well, as you can imagine.
Other questions?
Any legal challenges?
That's a great question, and that's probably one of the biggest fears, is are we going to violate HIPAA? So we actually met with Rahm Emanuel in Washington, D.C., and the Department of Labor when this kicked off. And they came back and gave us if you're going to, I used to be in the military, so if you're going to be on the point, that means you're the target, right? So we wanted to make sure that we had this all copacetic, and we got the okay. And we've been pretty public, so we haven't been challenged.
So you just talked about HIPAA. What about discriminatory issues?
Well, that was part of the discussion with the Department of Labor. There are states that occasionally want to change the state level perspective on this. But we have not been challenged this area, and we feel very confident that because we are making it around certain measures that are modifiable, and we also provide programs free of charge to individuals to help them on their journey, that we are in a good place. We also wrote a white paper as well that published all the reasons why this would be, these particular measures were the right measures.
And is that publication on the web?
No, it's
The white
not,
paper.
but I'd be happy to send it to you, Steve.
Thank you.
Recognizing that all of your employees do not get their health insurance through you, maybe through a spouse, how did you engage with folks who were not carrying your insurance to incent them and get them to participate as well, because their productivity is as important as those carrying your health insurance? Obviously, you couldn't have the same kind of health plan incentives. Did you set up something special for them?
So that's a great question. That's actually been one of the biggest difficulties, is channeling communication for one population. So we purposely made the Jumpstart platform, which is our single source health information portal, to all members. And then we added a twist. We made the last challenge open to all friends and all family members, and we defined family very loosely. I mean, Beth is here, she knows my wife. I went to Minnesota in my wedding. I didn't realize the entire town was related to my wife. I mean, so the entire town of Hector, Minnesota could have been part of Jumpstart. We really loosened up the definition of family member, so that because we also know that our social groups and our influencers may not be in the desk next to us. So we do have that single platform and we encourage people by asking them to join teams, and then teams can do challenges to each other, and then we actually provide incentives financially for what happens is if you hit certain points, that means you've qualified, you get badges, you get a certificate, and then if you hit certain other points, your team is entered into a drawing for cash prizes. What's interesting is we're now looking at how to make those prizes certain items in our grocery store.
Another
Kind of
question.
keep it in the family.
So I don't think you mentioned this. Do you still hire smokers?
We do hire smokers. We're not like the Cleveland Clinic, but the Cleveland Clinic has a different justification because of the nature of their business. So we do, but we also have a policy of no smoking anywhere on the property, which means even our parking lots. Yeah. And I don't know what our actual smoking rate is. I think it's about 18% is our prevalence of smokers. But that's the last I heard. And our obesity prevalence, I do know, is about 20%, 20 to 21%. Our goal is to beat Colorado, but we haven't gotten there yet.
Yeah.
So Colorado's just going to increase. So
that smoking rate's about 2 points below national average. Yeah. Another question. Yes.
What is the cost of your incentive program compared to the return on investment?
Right. So if we look at the average premium discount, it's about $800. Not everyone gets the full 1,000, as you can imagine. It started at a premium discount of about $600 when we started this program. But as people, made this, which is what we wanted to see, it slowly increased. So it's about $800-something is the amount. And then our differential was $1,900. So about a little over, just on a pure medical spend. This is not pharmacy. This is not dental. This is not vision. This is pure medical spend. It's about roughly 2.2 ROI. Then why we wanted to create this database is I want to create this more holistic view of productivity and all the other costs and get a better understanding.
Other questions?
As you work through the year, it's one thing to kick it off and you have wonderful starts. What have you found is needed throughout the year to keep the momentum going so that it's more than just the kickoff at the beginning of the year? Is it a monthly thing, a quarterly thing? Obviously, the apps give you day-to-day, but from a corporate level, how often do you need to be talking about this?
We're playing around with that. We actually, this year, did 4 challenges. And each of them, the shortest challenge was 2 weeks. We're playing around with lengths too. Shortest challenge was 2 weeks. Now we've kind of felt the sweet spot was about 4 weeks. And we changed the topics to embrace other people. So we had a challenge that was purely just track your sleep. We gave them apps on the phone that they should use. We gave them devices that are told them about. We didn't pay for the Jawbone up and those other devices, but there's free apps out there. And we gave them, the Pittsburgh Sleep Quality Index and the Stop Bang Index, and I gave a talk on sleep. So that drew certain people in that normally wouldn't have gotten involved. Then we had one just on eating produce. We partnered with our produce department. We gave coupons out, and we just asked people to track their produce. And then we had a cardiovascular one. So we had 4 different challenges, and one was all fitness-based. The first one was Olympic fitness-based. We're going to be doing a challenge coming up in January that I am really excited. It's taken us a long time to get to, but it's all about brain and framing and memory and cognition. And we're partnering with our leadership and development to do that. Because I believe resilience, and maybe it's because of my military background, but I believe resilience has a direct interplay with health and our well-being, and so we're trying to figure that out. So to answer your question is we do pulsate this with several different challenges. I don't think 4 is necessarily the right answer. We're going to scale back to 2 to 3 next year. The other thing I think is that feedback loop. My goal was to get as many people enrolled into the platform as possible because we send them messages. And the other thing we do is we've integrated it into the stores now. So we have team huddles, and we have safety and wellness huddles. I mentioned it to somebody here that we do this unique program around positive observations. And I'm going around to 40 different cities, me or my staff, talking to all the assistant store managers. It's been a huge undertaking, but we've created this program where we ask people to provide a positive observation, something they've seen somebody else do that was good, that prevented an injury. But now it also is around health, and we're giving them examples of how to write that. And then the concept is you write a thank you letter to that individual to say thank you for X, Y, or Z. Trying to create this culture of honoring and this culture of really trying to find the positive and not the negative, because everybody in this health journey, we all know where we're failing. What we need is encouragement for when we do something right. Yep.
Another question?
What effect, if any, has this program had on Safeway's workers' compensation costs?
Yeah, so that's a great thing. We are also wanting to highlight that at some point. We want to get the data, but we have one of the lowest work comp costs in the industry according to the folks who run work comp. I don't oversee that. I'm involved in strategy for the company and for Safeway Health, but we are partnering with them. I know that our injury rate is very low, about between 4 and 4.5 per 1,000. So I don't know how that compares to other industries, but for our industry, it's pretty darn good. And we do have a waterfall chart that shows with confidence intervals, not a waterfall chart, it's I don't know, I'm blanking on the right chart, but it has confidence intervals to show that our total work comp per employee has gone down over the last 4 years.
Do you pay for memberships to gyms or, say, the entry fees to a marathon? I mean, are there benefits like that for the employees?
Yeah, I'm about ready to do the Army 10-miler with the team, and we paid for the entrance for the Army 10-miler. We have a lot of participants in the Nike Marathon in San Francisco. Each division kind of decides on what they're going to sponsor and have people participate in. Gym membership is fairly similar. We have discounts for certain gym memberships, but we don't completely subsidize gym memberships. And the same is true for Weight Watcher programs or similar programs. We're increasingly wanting to provide those programs via that One Health platform because we believe you can do the support group and counseling. And we've recently hired 2 dietitians on our staff focused on providing programs that can be scalable through the employee base.
Do you know of any evidence to suggest that simply purchasing gym memberships for employees or even having a worksite gym actually reduces costs and improves wellness as a single effort?
No, we don't. We don't because it's hard to collect that data. And then I think one of the difficulties, one of the participation ways of getting a premium is that you have to document that you've gone to the gym. And I don't know about you, it's just documenting is just really not something I like. And so we rather just say this is your outcome, and how you get there is up to you. Our campaign over the summer, by the way, is make a simple change. Let's start walking. And it's just going to be all about walking, getting up out of your chair at work and just moving. And but to answer your question, it's really hard to get the data, so I have no idea if it's making an impact.
Yeah, and reviewing the literature, I specifically asked about that and could not discern and that simply buying gym memberships actually has a return on investment. Other questions?
I have two more questions. Do you have, as part of your program, health coaches for people who maybe don't have the right scores? And if so, how does that work? And then secondly, how do you deal with the taxability of your incentives? And how have you thought about that?
Great questions. Yes, we have telephonic health coaches. We also have online coaches through our One Health platform now. And what we're trying to do there is our health coaches are telephonically tend to be RNs, but they also could be dietitians. Sometimes we have a behaviorist there. The online is peer coaches. So we're really wondering, can you create the scalability with peer coaches? You know, studies from the YMCA, if anyone's familiar with the diabetes program that the YMCA is launching through lay individuals, have found some very good results. And so we're interested in the peer approach as a way of coaching through the medium of the online social network piece. But yeah, they do have free coaching, both in telephonically as well as through the online medium. On the second question, yes, taxability. So that's a tough one. So if you give a $200 cash incentive, that's not trued up. So they'll see something less than $200 that shows up in their paycheck. That's why we actually went away from gift cards. We're trying to figure this out. We're wondering how to do with the grocery issue because you get a gift card for $50, but they see a decrease in their pay, and that's not a very satisfying experience. So we're trying to figure that out, but it's tough. Right. So that's a policy change. We need to be working on a policy on that one.
I think we have time for just one more question. Anyone from the distant sites? Okay, I will take the last question then. So you've been on this journey, Safeway has been, for almost 10 years, and it's become a fairly sophisticated program. And I'd like to acknowledge Futura Corporation, who's starting that kind of a program as a pilot with St. Alphonsus right now. But what would you suggest to companies how to actually take that first step and get started towards such a sophisticated program?
I would say that the first step would be like the simple change notion, you know. Don't be afraid to take it. Take the step. I think that no plan survives first contact with the enemy. That's what I was taught when I went to West Point. So you're going to have a plan. There's going to be some obstacles, just like it was an obstacle for me to get here. Okay, I got it. But leadership is about, really, to me, leadership is critical. And to me, the two key levers of leaders that I was taught was alignment, making sure everything is aligned, so there's to what you're really supposed to hit, so you're hitting the target, and engagement, getting all your leaders on board with this, talking to them, getting them to embrace it. And if you can get alignment and engagement on this kind of a program, just like on any program, I think change will occur. But first thing is to take that step. And don't worry if it gets a little muddy.
All right, Dr. Bradley, again, thanks so much.
Thanks.